talk about the nearly 11 million, 10.5 million children that die every year needlessly because we have the preventive or curative interventions. How many of those, what's the burden of child mortality that in fact lies among the urban poor? We don't know that. We can do a little better with urban, but even that hasn't been well articulated. We need the numbers, the data, to make the argument stick. We also need to show some successes. And with all due respect, Siddharth has done tremendous work. I'm in awe of the work you've done in really a pretty short time. I mean, you've been involved a long time, but this work has been marvelous in its growth. But still, do we have any city where we truly have addressed the issue of urban slums across all the slums? Where we've taken it to scale? That's what we need to do. We need to focus our efforts. We need to pull NGOs. We need to pull policymakers. We need to pull municipal authorities as well. And we need to focus and get at least one success story out there that we can use to convince all the naysayers that you can't make a difference in cities. We know we can do it. We've been doing it on small scale, but we've got to do it at scale in at least one place. Okay. Still with me? Let me just share a few other quick thoughts. I think my time limit is about up here. I'd like to stress a few more opportunities and then skip to some questions for you. I mentioned before the private sector. I think that the private sector, both formal and informal, poses enormous possibilities in terms of the delivery of health services, and improvement of health status for the urban poor. I think there are advantages in working much more closely with municipal governments. We have to work with the national governments or equivalent, but we really do need to focus on the municipal governments for one reason. They often have the ability to raise taxes. Local taxes, and taxes can be put to use in the context of health. From the perspective of delivering the most effective, cost-effective child health interventions, the core package that we now have good scientific evidence that works, for pneumonia, for diarrhea, in many countries in the urban settings for malaria, and for the nutritional deficiencies and malnutrition. We can, in fact, use community-based health providers. We can, in fact, use minimally literate folks from mothers and family members from the poor parts of the urban environment to provide services. We can work more effectively with the informal sector as well. We have examples from rural societies around the world that these work and that they're cost effective. We have not done enough of it at scale in urban settings. Clearly we need to link the different sectors. Not only water and sanitation, which is clearly critical and contributes directly to health or non-health. We need to look at the economic issues, and certainly countries like Bangladesh and the Nobel Prize winner last year have looked at very effective micro-enterprises and how they can also be linked with health services. But I'd also like to pose we need to look at education, particularly maternal education. All of the studies show that maternal education is one of the most powerful determinants of child survival. So when we start talking about child health in urban settings, we need to look at maternal education. Clearly there are opportunities and challenges, but I believe there really are more opportunities in urban settings, and we simply need to pull our resources, focus on them, and begin to address the many lessons learned. India, for example, has had numerous World Bank-funded urban projects. And I know that you're aware of it, but how can we build on a legacy of projects which many donors, big ones from the World Bank to smaller ones like NGOs, have in fact learned, but pull them together into an aggregate model, apply it at scale. I think if we do that, and I believe we can do that, we will begin to make progress in urban health. With that, Siddharth, let me ask you a few questions, all right?
Let's give her a hand first. Well done.
I actually should, if I may, before I ask questions, I want to share a quick anecdote, if I may, because one of the things I didn't bring out in that, I was trying to be more consistent here and rigorous. But frankly, to me, having spent a fair amount of years working among the urban poor in Asia and Africa, and really working in many of the hardest core slums. I worked in, particularly those of you who know Nigeria, there's an area of Lagos that's literally translates into the jungle, Jeguli. And in that slum, which actually had quite a lot of violence, the reality was that most people, the vast majority of people, were wonderful. They were really kind. They worked hard. They often had many, 2, 3 jobs to try to maintain a minimal standard of living, obviously very minimal. But it was just the 1 or 2 bad eggs, that soiled that whole environment. And so I think when one goes into urban environments, particularly urban poor, often very dangerous looking areas of town, most people are quite good. And I've had more than one experience that the poorest of the poor, they seem to share more than those of us with more riches. I mean, they have nothing, and they will always find a place for you to sit. They will always try to find something to share with you, even if a glass of water, which may cost a lot for them to buy from the truck down the street that brings it intermittently. And so I guess to me that's the biggest hope, that really resides in the humanity that's the core of urban poverty. Thanks for listening to that. All right. Siddharth, I'm only going to ask a few. After this, I'll ask you some more. But there's, again, a lot of richness. Absolutely. So that's why I said I'll limit. But there's 2 in particular that I'd like to ask you. And one of them is kind of the standard one, don't worry. But it has to do with what are the costs of the interventions that you looked at. And have you done any, comparison between the different modalities, the different approaches in terms of cost and effectiveness, if not cost effectiveness? And along those lines, have you begun to make any plans or looked at shifting some of these costs to sort of longer term, more sustainable sources?
Yeah, we have tried to study costs, and definitely the most inexpensive approach is the ward coordination approach, where we do not have any sub-grantee. We just fund one person who basically we support for her travel costs, which works out to something like 4,000 rupees a month. So that is the most cost in terms of most inexpensive, but it has low benefit as well. In terms of how to take these programs, make them sustainable, we have some options that have begun to emerge in Indore. The situation is stabilized to the extent that those 9 cluster coordination teams that we talked about, their costs are not very high, and they can continue to take the program for a fairly long time, and the cost for them would work out to approximately 750,000 per year for a population of about 200,000. So how would that? 50,000 rupees, Indian rupees per year for about 200,000 people. And they would be able to continue the demand, supply, and linkage activity. Here the services are all government services or private services, but we have not provided any service in Indore. Unlike Agra, where we are actually supporting 2 urban health centers because there were no services in those areas. So the cost in Indore works out to this. The Agra costs are definitely a little higher, but with this population being large in one of the urban health centers, it still works out to be pretty modest, about 60 Indian rupees per person per year.
60,
which is $1.50, I think.
We'll open it up to the floor now for some questions. You have to wait for the microphone.
Good afternoon. My name is Timothy Kane. I direct the Office of Community Service at GW, and we're trying to engage students mostly with domestic community development, but we're also expanding to some international development. And I have two questions. One is, have you done any comparison, when you talk about the illegality issue with the slums and the sort of illegal living situations, with in the United States with sort of the undocumented immigrant populations and trying to figure out strategies to get services to them? Have you done a comparison with that? And the second question I have is, my office and GW and many other universities in the United States, we promote service learning where we have students as an incredible resource for the community, especially around assessment. And have you rallied university scholars and student populations in India to help do some of the assessment work for you around surveys? I can think of one example. We have a urban geography class, and one of the sort of the learning outcomes is to create maps and to learn how to do that. And so students go around with GPS, and they've mapped for some of our community partners, you know, different services, different needs, different assets within the DC community, and it's been a very helpful resource for some of our community partners. So those are the two questions I have.
Yeah, I think the second one first. We have utilized students of what in Delhi is a fairly famous School of Planning and Architecture for the mapping process. So many of these maps are actually made by students who come to us for their summer placements, summer internships, and during that period they go to cities and map out the cities, plot the slums, and create some reports. In some cases, because their summer placement is usually 6 weeks, they may leave it half complete, and there would be some more work that is required. For surveys, we do have a lot of students who come to us for summer traineeships. But what we have realized that these surveys, if you're doing a fairly big survey, these surveys are very big. They have a sample size in terms of women of about 3,200. So they take a very long chunk of time, and a substantial number of surveyors also. Usually a university sends us 2 students or 3 students, so that does not usually work out very well in terms of surveys. But yes, they have conducted small studies, and this year we are again going to receive some students, and I was thinking that they could probably, there will be students from foods and nutrition courses in India, and they know how to measure weights, and we could get them to do some study on the nutrition status. In terms of legality versus the illegality, are you asking whether those which are illegal are more deprived? Was that your question?
Actually, I was thinking in the United States, we also have challenges around providing services for undocumented immigrants. And I'm wondering, there's been some creative and innovative strategies to address getting services to those populations. And I'm curious if sort of like a case study, you've compared what has happened in the United States in terms of successes and challenges with what you're working with the illegality issues in India.
Yeah, no, we've not compared to how, I was hearing about this a lot on the television, more with respect to the political debates that are going on about illegal immigrants. But we've not done any comparison of that sort in India. But what we've been able to succeed in doing is to get the government to agree to, issue a directive that all urban poor clusters, we also, started using the word urban poor cluster or vulnerable clusters just because sometimes the word slum has a definition attached to it, and then people get only the slums will be served and the non-slums will not be served. Those sorts of situations arise. So that has been something which has happened, and the Secretary has issued the circular that all slums and vulnerable clusters of the city have to be mapped and served through the Urban Health Program.
Which is no small issue, because a lot of those are unmapped. and unofficial. And to get a secretary of a major state to sign off on that is a major political issue. So that's the kind of lesson for here, perhaps, that, you know, it's something that's there in terms of the immigrant issue, illegal immigrant issues in the states, but you still have to deal with them. John?
John Barraza with USAID's Bureau of Global Health. I've got 2 comments and 2 questions. So one of the comments is just to say that I partly agree that this idea of trying to get better data in urban areas is going to be an important part of the advocacy effort. We had started doing that with the DHS. It's kind of fallen off. I think that oversampling over urban areas, that will better disaggregate those data, will give us some insights and be really important in terms of advocacy. So we should definitely make a push to reactivate that. This idea of having a model city, I can't imagine we do, and we don't really have very many model cities in the U.S. There are cities that are touted as models. One of the ones that has been making the circuit for a number of years is Curitiba in Brazil, where the mayor seems to spend more time on the road talking about the city than actually governing the city. But I don't know how that works. And there are other models. I mean, if you traveled in China 20 years ago and traveled to China today, you would see cities that have been completely transformed. But that's also in the face of some unusual circumstances. One is economic growth that's been very rapid and largely confined to cities. It's still in the face of, very stubborn rural poverty. And at the same time, it's not a democracy. So the ways and the kinds of things you may do in China, which is essentially to bulldoze poor neighborhoods and turn them into modern parts of cities, can work in China, but doesn't work as effectively in, say, Mumbai, where they can't bulldoze slums in this neighborhood. So those are my 2 comments. And my questions concern leadership and money. And one of the things I had an opportunity to do recently was look at some urban slums in Indonesia. I was there last September. And one of the places I visited, it was these are not vast slums. Indonesia tends to be a little bit better off than many places in South Asia. And so there are pockets of poverty within the city. And you go, and one of these places had this incredibly dynamic community leader. There's not a mayor, but he's an incredibly dynamic community leader. So then, and you see the way that they brought in, and because of his effective advocacy and understanding of the community's problems, has been able to connect to all kinds of services. So my question is, we do these kinds of things trying to figure out models that work, but in some ways, should we just be trying to foster leadership? I mean, can we just be making investments and trying to really develop the skills of people who have some inherent leadership capacity and get those people the skills that they need to be the advocates that they want to be? And that would be another model, not one that involves necessarily the NGOs or the ward coordination. And so the second piece, the second part of the question concerns money. Actually, the Agra model really concerns me because I don't see it as an innovation that's specific to an urban area. It strikes me as being the kinds of things we've done in rural areas. You don't have services, you give money to an NGO, and they deliver services. And it doesn't actually seem to exploit any of the particular situations, for example, interface with the private sector or other kinds of things that could be brought to bear on the urban problem itself. So I'd like just to talk about that problem of the sustainability of that third model. And then the last part of the question concerns the comparison in terms of sustainability between the ward coordination model and the CBO NGO model. So we've discussed this question in the past. And the ward coordination model definitely is to some extent more sustainable because it doesn't cost very much, but it also doesn't seem to accomplish very much. So how has that thinking evolved over the last couple of years? If you can comment on that as well.
Okay. I'll take up the leadership angle first, and I think your point is very valid, and our experience in these 2 cities as well as our studies in other cities where we have not initiated programs, but we've definitely encountered the type of people that you talked about and who are very knowledgeable, and they want to utilize whatever little effort if we were there for a month or a month and a half. And in Indore, actually, the slum leaders have evolved into these 9 organizations, 7 of which have become registered. And we are noticing that they have very powerful leadership abilities, and we have nurtured them, and now they can advocate for their respective clusters quite effectively. I think that definitely has shown a lot of promise. The second point you had was about Agra. Yes, you're right that it is not really an innovation in that particular way, but it is basically to address a gap which was there not only in terms of services but also in terms of an example in Uttar Pradesh. The government of Uttar Pradesh had no example of working with NGOs for expanding services. The only thing that they were thinking about is to establish a new urban health center, contract it out to the Public Works Department. So the idea that Government of India has been encouraging is to stimulate the state governments to think of ways of doing things which are different from the way they were doing things. So it, in some ways, in the innovation for them may not appear to be an innovation for us. And the hope is that if it gets established, the government officers in Uttar Pradesh will start believing that they can trust someone else in doing things and not think of doing everything themselves, with the traditional approach of setting up a health center and hiring doctors, and then those doctors no longer want to work there because, as Diana said, they do not want to go to the most deprived settlements. So that is the challenge we have in Uttar Pradesh, that we are trying to establish something which is not very innovative, but since it's not exactly there, if it gets established, hopefully it will stimulate people to do more work, at least on the same lines in Agra or in other cities of UP. The third question you had about the sustainability of the ward versus the NGO-CBO model. There has been a lot of thinking since we interacted, last when you mentioned. And what we have realized is that probably in future, wherever we would have a scenario like this and we would have something at the community level, probably the leadership idea that you also mentioned, it will also come up very clearly in Indore. We would now in future have a combined approach where these leaders, as they are nurtured over a cluster of about 15,000 to 20,000 or 25,000 population, depending on the situation in that specific city. And then they themselves are able to, through support from either UHRC or whoever the facilitating NGO may be in that city or whichever agency, they are able to form this sort of a ward coordination committee, so their leadership gets formally accepted in the system. And this is what we are trying in 5 wards of the NGO-CBO approach in Indore itself, and hopefully in a year we will realize and see how exactly it is working, what difficulties they are facing. Are these leaders who are still basically slum leaders, are they able to handle this? They may need some help, some support, but are they able to? So that seems to be the direction that we'll get.
Diana?
Yeah, I just wanted to add one comment, actually 2. But in terms of the model, I want to clarify a little bit, because I wasn't talking about a model city, if that's what I imparted. I was really talking about the issue of a delivery system, a health system, that in fact takes into account all of the areas of poverty and look at it from a system perspective and do it at scale, not in one or a limited number of communities. So the issue of a model of perfect city, no, I wasn't going that way at all, and I'm certainly familiar with some of the efforts that way, but I'm not even sure those so-called model cities actually were addressing the issues of delivering services to the poor, and that's really what I want to focus upon, and really consolidating the different approaches into a more delivery system model. Secondly, though, if I may also address the leadership issue. I think leadership in this context, and again I'm focusing more on the delivery of health services to the urban poor, is necessary but not sufficient. I think that there's also leadership at the informal or among informal as well as formal leaders, and I think both are necessary. But I think we also can't be naive about this. I mean, the reality is in many poor settlements, in fact, by developing leadership capacity among the poor, it is often seen as a threat by the government structures. And in fact can be dangerous in some places. So it's a little bit dicey. I'm not advocating not to develop it, but I'm just saying one also cannot be naive sometimes about some of these larger political contexts.
Okay, my name is Haley McAckern. I'm from the School of Public Health and Health Services at GW. And my question addresses governance. We've been talking that good governance is very important. And I was wondering if you could give me 5 to 10 concrete examples of what good governance looks like in India and for India.
Only 5 to 10.
I mean, when you say 5 to 10, you want me to name those cities or
No.
basically explain how good governance?
Give an example of what good governance looks like, not only the city, but the characteristics that we're looking for in India.
Good governance would basically be that the municipal body of that city is able to take responsibility for health services. So, I can give you examples. There are several cities in India, even medium-sized cities. The large cities have large municipal corporations, and therefore their capacity is better than the municipal body of a small city. But even some smaller cities have fairly active and good governance. One of the examples is Bali, which I mentioned among the listed and unlisted when we were calculating that. There we noticed that the chairman of the municipal body, the vice chairman and other members, these are elected representatives, were very responsible, very informed and very much engaged in the whole program. I'll give you examples. In this small city of about 3.5 lakhs or 350,000 population, the municipal body has 2 hospitals. Even in large cities like Indore, the municipal corporation has no health facility. Indore is 2 million plus now. And this city with 350,000 has 2 hospitals, which they have built through their own resources, collecting donations. There is what is called there the Lilua Cooperative Bank. They have provided them some resources. And they manage it in a particular way. They were very eager. Another aspect of good governance is that they were eager to go along with our team to ensure that no slum was left out. Initially, when they suggested that their elected representatives would go to all the wards, we were a little scared. We thought that they would try to, produce hurdles from reaching the underserved. But they were actually very helpful. They actually wanted to do that. And all these are aspects of good governance. Another aspect of good governance which you've noticed in other states like Karnataka and Kerala and Tamil Nadu is that for outreach services they have weekly tour programs of the A&Ms which are prepared in advance and monitored by the supervisors. Those are also examples of good governance. As compared to Uttar Pradesh, where an A&M would go whenever she wants to go for how long ever she wants to go. She may spend only 20 minutes in that slum, immunize 5 children and, complete her outreach for the purposes of outreach. So these are some of the distinct features in good governance. The other angle which is worth considering is that in India, even though decentralization to the municipal body is there on paper as the 74th constitutional amendment, it has not actually happened or not actually been translated into reality in many of the states. So that also compromises the governance ability of the municipal body, as well as also the capacity of the leaders. For example, the leaders in Bali that I talked about would be very different from the type of municipal chairman you would have in Uttar Pradesh.
What about accountability, transparency, budgeting, things like that?
Yeah, those are more difficult questions. I think wherever in India they have tried that. They have tried that in Andhra Pradesh. I think it remains still very cosmetic. I mean, if someone comes up with a bright idea that they want to do participatory budgeting, and you have the money to support the services of a person who has all the capacity to manage it and write it up in a way that it is internationally documented, then you will feel that it has been done. But I don't really think that India is ready for that situation. It does not actually happen. Any such effort which is done where the people who have to manage it are not ready for that would more or less remain on paper. So I think we still have a long way to go. It may start happening from the southern states like Tamil Nadu, Kerala, Karnataka and Andhra, where there's some likelihood, but still they also have a long way to go.
Maybe just to follow up on that question, maybe where is UHRC's vision in the future in terms of dealing with the governance issue? Because to me, that's one of the foundations of sustainability. And I know it's a very delicate issue, but where are you from your own NGO and from USAID standpoint moving forward, not only on the service delivery side, but from the governance side?
Yeah, that's a very good question and a slightly difficult one, but I'll try to respond to whatever level our thinking has evolved. On the one hand, we are dealing with it to make at least the central government accountable in terms of having a policy decision and resources. That is the first stage, because in any federal governance structure, which I think is similar to the United States, the same as in India, it is the central government which will at least bring the main policy mandate. And so at that stage, I think we have met some success. The formal announcement is still awaited, but we've measured success. There are some documents there on the web, the slum health guidelines, and there's some things there that are there. The next level is at the state government, because health is a state subject in India. So basically the governance will be at the state level. And there we try to encourage the state governments to develop some specific mechanisms to ensure that there is accountability at the state level. Something like a state level urban health coordination committee or a review committee or a task force or whatever term they would want to use for it. And then the third level is at the city or the district level. And I'm using both words because of the same reason that the 74th Amendment has not percolated to the city level in many areas. So the governance still remains at the district level, which includes rural and urban areas, and it is the district magistrate who's mainly in charge. So in those districts, and in many, we have tried to encourage them to form district level urban health committees or task forces or whatever you call them. And we are also encouraging the central government to mandate it in the policy or in the design itself, so that the circular, whenever it reaches, it stimulates them to form those task forces. And what the effort that we do and the vision that we have is that in the next few years, as these task forces or these committees come alive and there are some champions that emerge, we hope to take them for study tours to those better governed areas like West Bengal, like Karnataka, Tamil Nadu, so that they observe for themselves the example that I was giving you of the weekly tour programs in advance, the monitoring of those. It does not happen in the northern part of the country, but it is happening there, so that we stimulate them through those visits.
Sir.
Hi, I have your namesake. My name is Siddharth as well, Siddharth Shah, and I'm the director of Psychosocial Assistance Without Borders. So I'm going to ask a question bracketing mental health a little bit more. Psychosocial Assistance Without Borders, we do work mainly with NGO workers for their mental health, actually. But time and time again, I'm in touch with people, and I've worked in Gujarat, Tamil Nadu, Sri Lanka, and Pakistan around these issues. Benzodiazepine use among people for anxiety control, dysphoria control. And specifically, Dr. Silimperi, you brought up this issue of the informal sector. And this is one of those areas where pharmacists are acting as very much the conduit by which people self-treat. And I'm also interested in the informal sector in terms of bringing in positive ways traditional healers. And this often becomes an issue. And by the way, I'm asking a question that's for everybody. I'm asking for questions like if you want to respond to it philosophically, policy, or practice-wise. But I'm looking for, and this is a problem of scaling, that once we scale, most of our models are scaling allopathic models. And we don't have very good ideas, although WHO often sort of chides policymakers that we have to continue to involve traditional healers. I don't see that as being a part of how to scale things. And so one of my pet peeves, I'm a physician, I teach in cultural competence courses, is that cultural competence, at least in the United States, is, even though philosophically it's very heroic, in practice it is how can you understand the client or the community well enough to be almost liked well enough so that you can deliver your allopathic treatment, and so that the client or community complies with an allopathic treatment, and the more lofty ideal that you understand and possibly even support traditional healing methods, other adjuncts, is kind of lost. So my question would be what are instances in which you think this larger idea of cultural competence, or what might be called ethnomedical competence, is utilized, or if you have any vision, or if you want to problematize it. I'd like to hear anything around this subject about scaling, so on and so forth. Thank you.
Sure, I'll jump in with a few thoughts, and then my colleagues add to them. I like that term, actually, that's used, ethnomedical competence. There actually are examples, increasing numbers of examples of working with both the informal private sector, chemists, drug vendors, the informal pharmacists, if you will, certainly in a number of African countries in particular. But the one that stands out perhaps is in Tanzania right now. There's an effort to work with them in the context of an accreditation type model, so developing their skill-based, not only in terms of management of medications so that they're not out of date and so forth, also that they in fact utilize the correct, for example, antimalarial medication that's now been recommended by government policy and so forth. But then lastly, that they actually know how particularly to administer those medications correctly. I have to say that a lot of the focus, certainly that I'm most familiar with, has been more on children, on the treatment, because a lot of times people will use the informal, the pharmacists / vendors, and informal healers, particularly, or traditional healers in particular, for children's health, children's conditions, coughs, colds, and so forth, diarrhea. And so we focused a lot more on that. But there in fact are examples globally, but Africa in particular, and this accreditation model in Tanzania that I can give you more references to. And that's more the informal sector. Now, your question about traditional healers, often when we look at delivering, again, particularly effective child health interventions at a community level, NGOs have been especially involved with reaching out to traditional healers in many different cultures, again, Asia and Africa, to work with them, again, to bring to them some allopathic ideas, but also to work with them to identify if any of their current remedies were harmful, to try to get them to change those, frankly, negotiate, but also to support the ones that in fact often there are effective, very effective remedies out there. So the issue has been more not trying to change them, but trying to identify if there really were harmful practices, to work and negotiate with them. And also, many of them are quite willing and interested in also adding to their panoply of skills some selected allopathic skills, in particular around very common diseases like malaria. Now, how that goes forward at scale depends often on government policy. So when governments, in fact, have recognized traditional healers and are encouraging in their legislation and in their policies and their provider scopes of work to include traditional healers, that's one important step forward. But then, even when you have the policy, in fact, sometimes you run into the biomedical model as a wall. So the existing biomedical providers in the country, the doctors and nurses, often are the ones that are, most against working with the traditional healers. But again, there are success stories out there where they worked effectively, and some of those are in urban settings.
Siddharth, do you want to comment?
I mean, I would comment based on my experience as a clinician, and I think it's unlikely that legislation will be able to bring about what you're suggesting. Trying to integrate these things would happen more at the local level. Whoever the person in charge of that particular dispensary or health center, whoever is the local doctor there, if he or she is able to behave and interact in a manner that is non-threatening to everybody and is very inclusive, then possibly you could have an integration of both systems. And I think behavior of the medical professional is very crucial to the subject that you've talked about, mental health. If you're dealing with mental health and you are able to behave in a manner that half of the problems of the patient, as we are taught in medical school, would disappear, mainly because the clinician is talking to you in a way that it makes you feel good. So I think that way it addresses mental health and your behavior with the other forms of medicines. And in India, there are many other forms of medicines, like the Ayurveda, the Unani, and so many others, in addition to the traditional healers, that you can try and integrate all and at least reduce any conflict so that the community does not feel the disadvantage of any system.
I think that some of the issues that you're talking about, particularly when it relates to mental health, there are two major ones. One is trust and the other is stigma. And both seem to have to come from the community level, more a bottom-up sort of approach. And that's a tough one, because mental health in this world today really is a blend between public health and medicine. And you really have to deal with the larger side of the equation as well as the individual side. There are no easy answers, but I think some of that, see how you can begin to look at this from a community standpoint, even when you're talking about, a community of pharmacists, to really figure out how you dispense drugs, how you counsel, how you provide good drugs as opposed to not good drugs, and how you to deal with the issues of compliance and adherence are going to be keys to some of this down the road. But it's not a tough one. It's not an easy one. It's going to be tough, and we're facing some major issues. I was just chatting with somebody this morning in terms of our soldiers coming back from Iraq and the levels of depression and some of the mental issues therein. Upwards of 40% of the individuals or these sorts of issues are surfacing. How we deal with that on a community basis is going to be a real challenge even in this country. So it's a good question, but it's not an easy, there are no easy answers.
I just add that mental health is a major issue in cities worldwide, and particularly not only among the poor, but globally. And it's a challenge that has not been well addressed anywhere. Even the identification and recognition and the statistics are very poor.
Well, I think we've run out of time. Is there any other burning issue? Does anyone have one burning issue, Tony?
I'd just like to introduce myself to everyone here. I'm sorry I came in late. I was stuck in a bureaucratic training. My name is Tony Kolb. I'm the fairly new urban health advisor with USAID. And my job is really to promote people like those that are sitting at the end of the table here and help them in their work and try to spread the things that they're very interested in to other parts of the world and other parts of our agency. So I'm very much in the mode of trying to invite people into this cooperative effort. I have cards here if anyone would like to take one of my cards and let me know that they would like to be part of some of the mailing lists that we're developing on urban health, to receive some news of what the agency is doing and what others are doing. And if you'd just like to talk to me, find out more about what USAID is doing in urban health outside of India, I'd be happy to talk to you about such.
Well, I'd like to close it just by saying we've talked about a great many things, extremely interesting information in terms of the project going on in India. And I'm particularly thrilled about the progress that has been made, and must acknowledge that that progress is largely, if not totally, due to Dr. Siddharth's dedication and expertise. Challenges exist. The idea of an inevitable priority was put on the table. We've looked at different program approaches in terms of the community. We've talked about sustainability. We've talked about the complexities of urban health delivery in terms of people even leaving urban areas, for example, to deliver babies. We've talked about it being a unique time in history to really deal with this issue in the future. And I think our two colleagues have most eloquently dealt with all those issues. So let's thank them with a hearty round of applause. And I'm sure they'll be here. Thank you so much.
GW.